Yes, you can start.
Yeah. A very good evening and a warm welcome to all our dear delegates who are joining us today. Today we have with us Dr. Nikhil Verma sir. Sir is a principal at Ara Dental College and Hospital Udaipur, Rajasthan. And topic for this session is harmony of form and function, tissue management, abutment design and impression techniques in FPD. Over to you, sir.
Thank you, Misbah. Thank you, Shubham. Okay. And well, it's a very long presentation, so I will not take much time for anybody else, but I'll just shoot off because there are a lot many slides and it's a filled kind of experience for it. Okay. So let's start with success is not final, failure is not fatal. It is the courage to continue, and that really counts. That was told by Winston Churchill, who was a UK Prime Minister. So now, in simple words, this is what I'm going to talk about: tooth preparation, soft tissue management, and impressions in FPD. Now, that's a very wide topic, so I'll be running down a few slides very fast. Okay. So, whenever we start from the school, we think, okay, schooling is done, our 12th class is done. Okay, I have almost reached. So when you complete the college, okay, you say, yes, I have reached the peak, but you are actually into the clinical practice. And that time you realize the line is really very, very tall and it's very, very, very difficult. In current scenario, what we are actually facing in a private practice is uh, the patients are too hyperactive and they have so many questions. And those questions can be only answered uh, by a lot of your research, values, and experience. Okay, like if a patient comes to you and says, "Ki, Doctor, Sahab, you have put a bridge, and how long it is going to be, lasting for me?" That time is very difficult for you to answer, but you will have to answer because he's directly opening up a Pandora box for you, Pandora box for you for he's asking you the prognosis. And you cannot run away with the prognosis. Okay, you will have to declare the prognosis to the patient. And in prosthodontic science, I always tell to the patients, he, these are the indications, I'll just run them and while I'm talking. In our science, we have always one thing: the patient is going to talk to you about ki, Doctor Saab, whatever procedure you are doing, okay, and that procedure is going to last for how long, and you will have to really answer to that. You really have to cater to that question, okay, and to cater all those kind of questions, you will have to declare one thing is the experience of yours, how much you are going to survive with that FPD. Okay. So if you see this FPD, so it's a crown which has been given to the patient, but you really call it to be a good FPD? No, I don't think so. It's a good FPD. Okay. Now this FPD is monochromatic. It is having a black line. It is not matching with tissues. It is not matching with the adjacent tooth. So it's not a very good FPD. Okay. So sometimes you see that everything is perfect when you see it from very far. Like if you see this is a miracle mix restoration done post-operative restoration material used as a post-operative restorative material. Okay, and a crown was given to him. Okay, but when you just zoom in on this crown, you see that there's a lot of marginal discrepancies there. So finally, this crown is not good. Okay, so magnification is really very must, and whatever you do, you should revisit your things and see what you are delivering to the patient or what you're inserting in the patient's mouth is really very perfect. Okay, so see the marginal discrepancy. Now, this is what I was talking about. The patient is going to come to you and talk to you regarding your failures, when it is going to fail. Okay. So, there are a lot many research topics are there. Queries can be answered, like a meta-analysis of durability data of conventional fixed bridges. And, they told you the calculated, read the last line, the calculated overall survival rate was 74% plus minus 2 after 15 years. Okay. So, this is a idea you can give it to the patient, you can quote it to the patient if you have really done a good job. Okay. But 74% survival is a very good survival rate. It means you have really followed all the principle what was dictated to you in theory. Okay. A systematic review of survival and complications rates of fixed partial dentures after an observation period of at least 5 years. Okay. Overall, if you see the last line, estimated FPD failure survival rate, that is 95%. Okay, that is cumulative index, that is 0.0116, which is a good thing. Okay, estimated 10-year FPD survival rate was again 95%. So 95% FPD really survived. Okay, so that is a good data. So again, loss of FP due to the periodontal reasons. Okay. So the pool data says that, the same 95% जो है, they survive, which is again a very good data. Caries and loss of abutment vitality were the most common biological complication, while the loss of retention of FPD was the most common technical complication. Okay. So caries and loss of abutment vitality is the most common reason when you're going to go with the FPD. And loss of retention FPD was one of the most technical complication. Why technical? Because you forgot to manage the short clinical crowns. And I'm going to discuss how you manage the short clinical crowns. Okay. So there are many articles on this. Okay. And after 10 years, FPD survival rate again 74.4%. That is going through the article of Helena Agland. So this is again a fractured tooth, and this is what we can really turn into. Okay. So what are the principles of this we are going to discuss? That is tooth preparation, soft tissue management, and impression making. Okay. Then what are lab procedures, cementation of FPD? So this we are not covering today. So now, if you see this FPD, what do you see in this FPD? You see the, probably the color is also matching according to you. Okay. But if you see the gingival zenith, and the gingiva is really very swollen because all the teeth have been joined. And if you see this connectors, the length of the connectors is really, really very big, and they are impinging on the soft tissues. So this is not a very good FPD. Okay. On all three portions, this is not a very good FPD. Okay, so this is not FPD which you'll prefer, but these are the common FPDs which are going to be given by the common lab technician or a local lab technician to you. Okay, but the failures are not of lab technicians. Failures are going to be yours. Okay, so let's see what are the principles of tooth preparation: preservation of the tooth structure, retention and resistance form, structural durability, marginal integrity, and preservation of the periodontium. Okay, so we just go through the pictures and see preservation of tooth structure. How do you do it? Okay. Try to give the partial veneers rather than going for full crowns. Okay. But when we are talking about the partial veneers, that time, those times were different when they used to use a lot of gold. Okay. Because the burnishing of the margin, burnishing against the margin was really very, very good. Right now, in current trends, they are talking a lot about the ceramic partial veneers in the posteriors or ceramic inlays and onlays. But I differ in my opinion, saying that uh, these veneers, whatever you're going to give of zirconia or a PFM also, the modulus of elasticity of your original tooth and the ceramic is going to differ. It means the flexibility of the tooth and the flexibility of zirconia is going to differ. So finally, you will have a micro leakage there. Okay. So take a conscious decision while you're going to give this kind of, partial veneers. If you're going to give for a gold, it's beautiful. Okay. The partial veneer versus full veneer crowns, inlays instead of crowns, and supragingival margins versus subgingival margins. Now, this is the most debatable topic. We'll discuss on this when the time will come. Okay. So retention and resistance form, that is second most beautiful principle. Okay. Retention form is vertical and resistance form while giving oblique direction if you give a crown. Okay. So most of the time retention form is only called when you are going to eat a sticky food. Okay. So when you are opening your mouth, the crown is going to come out. But resistance form we really commonly encounter. And in this resistance form, what is there key when you're biting? Okay, so biting is not vertical. We are always applying horizontal kind of forces. Okay, at that time, if your resistance form is not really good, okay, the crowns will get dislodged. Okay, so this is retention and this is the resistance form. Now this is short clinical crown. Now, really very short. How to manage that? Okay. Some people will say crown lengthening. Okay, you can do the crown lengthening. Okay. But these are the things which you really should focus on. When you give a taper, okay, when you give a taper, the crown can come out in any direction. But when you give a retention grooves in that, the crown can come out and go in through only one direction. So these are the retention grooves which we should prepare when we are encountering the multiple grooves, okay? And but they should be all parallel to the each other. So one is control of the taper and the freedom of displacement should be reduced. Length, try to gain as much as length as possible because if you are going to give us supragingival margins in this kind of tooth, it will not work. Substitution of the internal features, that is through the grooves and boxes, okay? And limiting the path of insertion. The path of insertion and path of removal should be in the same direction and that should be one only, okay? So this is a good height, short clinical crowns. You can see on the right side, you have short clinical crowns, whereas the arc of rotation on both the sides, you can see the arc of rotation is resisting. So resistance form in the left side crown is really good, but on the right side crown, it will not be that great. Okay. Now structural durability, very very important. Okay. Now structural durability is the pertaining to the crown which you are going to give, whether metal, PFM, or zirconia. Okay. The rest C. Okay. So when you're going to bite, okay, the functional cusp needs a lot of bulk. If the functional cusp is not reduced properly, okay, the bulk will not be there, and the crown on a long term will fracture in this area. Okay, a metal probably will perforate, but a PFM crown and a zirconia crown will fracture in this area. Okay, the occlusal reduction is really very important. Functional cuspus bubble has to be given, and axial reduction should be monitored so that you don't get enough of bulk on the buccal side and lingual side or on the medial distal side. Otherwise, what will happen? The food lodgement is going to happen because material needs a strength. Like a PFM is going to have at least 1.5 to 2 of reduction on the buccal side is not there. Okay, so technicians tends to build that buckle, buccally too much. It's a over contoured crowns will be there otherwise. Okay, so this is inadequate and adequate. So for metal alloys, you have 1.5 on the functional cusp and 1 clearance on the non-functional cusp. For a PFM, you need to have 1.5 on the functional cusp and 1.1 to 1.5 on the non-functional cusp. Then on the zirconia, for all ceramics, that is 2 for the functional cusp and 1.5 clear on the non-functional cusp. Similar, almost similar to the your PFM, but not 1 Like PFM had 1 criteria, it doesn't have 1 criteria. It needs at least 1.5 So occlusal reduction, really very, very important. You think that you can flatten a tooth? No, you should not flatten a tooth. It is very, very difficult for the technicians to, make a crown. And plus, the on the left side, if you see the contours are there, so that will improve the retention form also. Okay. So this is thinning and this is too much of thickening. Not a really very good idea to do that. Okay. Axial reduction, you cannot be tapering on any other side. You should have a uniform axial reduction so that you can get in a uniform bulk on buccal side, lingual side, and the medial and distal side. Okay. Now this is when you give her too much of try to give her too much of taper. What will happen? This is going to be perforations. So when you see a perforation of this kind, now this is the common practice while you are doing multiple tooth, right? Supposedly the missing centrals and laterals are there, and you're going to do on the canine and premolar 8 unit bridge you're going to go do on the maxillary arch. Okay, so that time you try to overdo that. Okay, so when you overdo this, this is going to happen. So make sure that the bulk is monitored in your mind. Okay, and if you need, you can take a check cast. Okay, so if you've done a preparation, if you feel there is an undercut, just take a check cast, keep a micro survey in your clinic. Okay, mark with the help of micro surveyor wherever the undercuts are there. Okay, get back to the patient's mouth, reduce that. But the control of taper is in your hand, so don't try to tilt your handpiece on the buccal side or a lingual side, wherever you. I mean, keep it at a 90-degree angle. Keep it at 90 degree. No tilting. Okay. So this is again a very good FPD. And I'm sure that you are able to figure out which is the processes and which is the natural tooth. Okay. Wherever you see the air bubble, that is the artificial tooth. Okay. That is on the 2 is a one is a artificial tooth. Okay. And this is called as marginal integrity. Okay. Crown should be really merging and flushing with the, with the tooth. I'll show you few more cases. Finish line configuration, chamfer, heavy chamfer, shoulder, slope shoulders no use. Radial shoulders again, I mean, almost eradicated. Almost we are using chamfer and heavy chamfer nowadays. Okay, no more shoulders also. Knife edge is used in a tilted abutments. Okay, so this is a chamfer preferred for a metal restoration or a metal crowns. Okay, the metal crowns are a very good restoration. Sometimes you can really try in the posterior thing. Okay, so these are the slope shoulders. Okay, very rarely it was. I mean, for it, you need to have an indication to use them. Okay, and this is a shoulder or a heavy chamfer. Sorry. Okay, you can see on the right side of the crown, you see it is a sloped one. It is not a acute. I mean, it's not a 90-degree one. So that's why it's a heavy chamfer. Okay, so this is your shoulder margin, 90 degree. Okay, preservation of the periodoncium, the placement of the finish lines, where you're going to place the finish line, whether it is going to be supragingival or subgingival. Okay, so margin placement, this is a very good supraangival margin placement. And when you don't need, when you have good clinical height, why you need to go for a subgingival margin? Okay, so subgingival margin, if you really want to go, there are indications for it. But what is the advantage of margin placement supragingivally? They are duplicated by the impression without tearing and deformation. Whereas in subgingival margins, what will happen? The gingiva has to flow into the gingival sulcus and come out without tearing. So that is a difficult task. Okay, so I'll show you some good impressions also. So finish line should be placed in enamel whenever it is possible, not on the dentine, okay, or not on the CJ or not on the cementum. Okay. Supragingival versus subgingival margin. Definitely supragingivals are much better. Okay, but many situations are there in which subgingival margins are unavoidable. Now, those are the examples like caries, and when you want to increase the retention, okay, you need to go supragingival, subgingival. Okay, then for aesthetics, you need to hide your margins below gingiva so that the transition between the tooth and the crown is not seen. Then extension of the previous restoration. Previous restoration was like that; you cannot do anything. And last, trauma. If the crown fracture has occurred, and that is actually subgingival. So you need to go subgingival in this case. These are beautiful supragingival margins, and these are again subgingival margins. Okay. Now, how do you go subgingival? You just cannot cut the gingiva to go for subgingival. So I'll show you while managing soft tissue how to really go for subgingival margins. Okay. So this is a temporary and supragingival margins, beautiful margins, and this is the crown. Okay, so these are four beautiful looking crowns, and you can see really how the gingival genus has been maintained. Okay, and you can appreciate the equigingival kind of thing. Okay, and marginal integrity. Okay, this is when you look from the top. With soft tissue management for FPD. Now this is a common case which are going to come in your clinic. Okay, and at that time, if most of the dentists what they are doing is ki they are extracting these kind of teeth and they are putting implants rampantly. Remember one thing, for in a clinical practice, implant to do and earn is really very easy. But implant to maintain on long term is going to really, really, troublesome for you all. Okay, so try and save the tooth. If you tell the patient that I have tried to save the tooth, let it last for 3, 4 years. Okay, or I mean, that time you want to predict your prognosis. If the crown is going to last for few years or so, okay, what will happen? The patient is going to be really very happy that doctor saved my tooth, whatever amount it has lasted. And after that, the patient, if really the crown again fractures, patient comes to you, he is easily ready for the implant. Okay, so try and save this tooth because that is the way to go for ethical dentistry. Okay, you can really rebuild it. Okay, I'll show you a few more cases on this. Now, soft tissue management, where we need to manage, why we need to manage, we need to see why we need to manage. Okay, and how to manage. Okay, so let's answer where we need to manage. When you have a subgingival caries, so that time you will have to go subgingival. When you have cervical erosion abrasion, even for your class 5 restoration, you need to manage the soft tissue with the help of retraction, and sometimes you need to go for electrocautery in that area. Okay. When you have a deep class 2 also, if you can manage the retraction, it is good. If you think the a lot of gingiva is coming on the in the caries side, then you need to cauterize that area. Okay, and do the restoration. The ideal thing, what I'm trying to tell you, that the restoration should merge with the tooth, which is really very healthy, and it should, it should flush with the, restoration. Okay, restoration and tooth should be flushed. There should not be any foreign. Okay, so subgingival preparation for crown and veneers, luting of restoration. There also we sometimes we need to manage the soft tissue and subgingival tooth fractures. So why we need to manage? Now you see this, okay? If you give a crown, if you just make an impression on this, and if you give a crown, okay, you don't know where your crown margin is going to end up. So let's see what is actually there. This is after doing the cautery. Okay. So retraction or displacement of gingiva or exposure to the finish line is really very, very important. Okay. Again, you are doing, I mean, this is, I have done a double cord. Okay. So push the gingiva and you can see the fiber post also there in the 4 teeth. So these are sometimes really very necessary because a technician cannot give you a good margin until if your impression is reflecting those margins in the in your impressions and on the cast. See the margins, how they are beautifully they are seen, and see the gingiva. Okay, so at least 0.5 mm difference should be there. Okay, now finish line significance, the place where the restoration ends or begins, it should not be felt. Okay, if you run a probe, you should not be able to feel it. Yeah, minor, very minor at a micron level, probably you can really figure it out. Okay, but a food lodgement in that area should not be there. Okay, so see the crown, supranumeral margin, and what technician gives you and how it comes in the patient mouth. Okay, so they all three should be really very beautiful. Now, subgenual, preparation is it. You need to really practice. Okay, subgenual margins. And when you talk about subgenual margin, how much subgenual we should go? Okay, so let's talk about the biological width or a dento-gingival complex. The dento-gingival sulcus is going to be 0.69 mm only. So we are bothered about extending our margin into this 0.69 mm only. Okay, so we are going to go not more than 0.5 mm. So you can imagine how much 0.5 mm is. Okay, so all thing you got to do is you need to manage the if you go beyond 0.69 mm, then you're going to hurt the gestional epithelium. Okay, so recession is going to come there. So try to be in the sulcus only. Now, how do you do that? I'll just run through this. So methods of gingival retraction, that is surgical retraction, that is gingivectomy, gingivoplasty, periodontal flap procedure, electrosurgery, and rotary gingival curettage. Non-surgical retraction, which is the most commonly being done by us, that is copper band, rubber dam and clamps, retraction cord, impregnated and non-impregnated. Then retraction rings are also there. Mechanical methods means how you push the gingiva. That is physical displacement of gingival tissues used alone or in conjunction with the other methods. So this is one copper band. Rubber dam is very, very effective in doing a retraction. Okay. So this is beautiful restoration. Retraction cord, most effective in the clinic. Okay. But problem with the retraction cord, it's very difficult to place sometimes. Now, if you think that it is really difficult to just go with my presentation, you will really realize it is not that difficult, but it needs a practice. Okay. So these are the most commonly used chemicals, that is epinephrine, alum sulfate, aluminum chloride, ferric sulfate. Okay, but none of them are used now. Okay, what we are using is oxymetazoline. That is a nasal decongestants. Okay, so you can take nasal decongestant, and that is a oxymetazoline. You can use that. Okay. So how do they act on it? They are surface layer tissue coagulants. Okay. So what will happen? Surface layer of the gingiva, that is gingival sulcus, when it is coagulated. Okay. So gingival clavicular fluid does not leach out. So retraction cords are there. Okay, I will not go in detail, but I'll just mention you about thinnest and the thickest part. Most commonly will be 000, 00, and single zero. Blue, green, and red. They are most commonly they are not used because sulcus is not that wide. Okay, but 000 is always used in conjunction with 00. 000 you'll rarely use single chord technique. Okay, so these are the Ultra Park, that is my choice of retraction cord. They are the beautiful cords. How to manage? Well, this is a very important question. Okay, so there is single cord technique, double cord technique. We'll go with this only. Okay, this is the instrument. There are a lot of many arguments whether it should be serrated, non-serrated. I go with this simple, fine, thin instrument which is non-serrated. Okay. Now, general traction, how it is done. Okay. Preparation of suprarenal margin, I take the cord, okay, and with one hand and one tweezer, I try to push within the sulcus on the proximal side, okay, and then I angulate my instrument to 45 degree. You can appreciate how thin my instrument is, okay. Okay, so now your retraction is done, but on the distrobuccal aspect or distrolabial aspect, the gingiva is still in contact with the tooth. Okay, so this how to go subgingival again. I'll come back to it, but this is how retraction is done. Okay, so this was subgingival margin, and once you remove the cord, this is again a double cord technique. Okay, and this is how you see that the impression material has gone into sulcus and it is recorded. Now the margin has become so initially on the left side, left top corner, you have a suprarenal margins and then you prep it. Okay, you recorded it, and the margin actually, when you remove the retraction cord, you made the impression, the margin actually becomes the subgingival one. Okay, double cord technique. Many times you will have to use this. Okay, so how it is used? The smaller chord, that is 000, is going to be down, and a larger diameter, that is your 00. Okay, that is going to be on top of it. Okay, so this is 000. I packed it, but still the gingiva was in contact with the tooth. Okay, so then I used a 00. I removed that part also. You have to be really very very cautious. Okay, that uh, you really push the gingiva and you don't cause the bleeding. Okay, one sec. Problem. Yeah. Yeah. So larger cord should be removed slowly. Okay. And after 4 to 6 minutes. If it is still bleeds, apply ferric sulfate for 3 minutes. Impression should be made only after the bleeding stop. Moisten the cord before the removal. Okay, because you had used oxymetazoline there, and that is the that is surface layer coagulant. Okay, so that really fuses with that layer. Okay, so if you try to take out, what will happen? It will lacerate the gingiva, and if you lacerate the gingival sulcus, the gingiva will definitely go for a recession in that area. And that will not happen immediately. That will happen probably after 4 weeks or 2 or 3 months. So whatever subgingival you had given will be again supragingival. So if you were planning for a beautiful aesthetic, the results you will not get. Yeah. So this is a very good case. The patient came to me, and you can see the restoration which I had only done, okay, years back, and I had advised her to go for a crown, and this is what we gave her later on, okay. So impression techniques for FPD. So impressions are actually the reflections, okay. Whatever you do, okay, it is going to be reflected, and it should be really, as similar as possible, okay. So I'll not go for the requirements and all those things, okay. I'll just go with the directly the techniques. There are so many impression materials. Uh, After you have done the gingival traction, see again a good case where I have given 3 grounds. You do the gingival traction very beautifully. You make prep again for subgingival one. The margins again automatically they turn to the supragingival, and these are the beautiful FPD what you give. Okay, the impression technique they are, putty wash technique, single or monophase viscosity technique, or a putty reline technique. Okay, so this is your application of tray adhesive. Okay, and in a putty wash you spray, you mix the putty, load it in a tray, put some light body onto the tray and some light body in the patient's mouth, and make impression. The problem is that all the light body will wash away from this. Okay, so again putty reline with the scraping of the impression. So you make a putty impression, you scrape with the burr, or there are scrapers which are available in the market. You scrape everything, and then you mix the light body, and you put it in the spray in the patient's mouth and the tray. Light body stays, and it really gives you a very detailed impression. Then putty reline, that is a very easy technique to do, which is commonly done by us. You apply a tray adhesive, okay. After that, you just take a thin polythene, okay, and you place it on the tray after placement of putty. Okay, this is how the impression is recorded. You remove the your liner, okay, whatever plastic sheet you have put, okay, that is also called a spacer. So remove the spacer, and then you make a very good impression. And see how the light body actually is recording the impressions. Okay, so if the light body is there in the bulk, it will really give you detailed impressions. And the impression for the veneer, one of the most difficult impressions. See how thin gingiva, how thin the impression material is there, and it has gone in between the sulcus and it is recorded. Okay. Again, in a custom tray, sometimes you do it. Okay, that is heavy and light body combination. So you mix a heavy body and loading tray. So the putty will displace everything, but heavy body is comparatively having more viscosity. So sometimes they are really very good materials. Okay, so you spray the light body and you get a beautiful impression then here. Okay, so uh, this is again a polyether, beautiful impression material. single or monophase viscosity technique. And again, you have a tray, and you load the polyether into tray, spray something in mouth, and then you make a good impression. Now, polyether is having an advantage that is a hydrophilic impression materials, and on set it's the O-ring phenomena opening phenomena it set. Okay, so this impression materials on setting becomes very rigid. Okay, so they are classically used for your implant impressions. Okay, so I'll not talk this for the. So again, there are few failures, not mine, of course. They came to my clinic or they came to the college. Okay. So these are again FPDs which are done. The patient mouth, we had tough time in removing them from the patient mouth. See how they are done. See the radiograph. Okay. And this was done with a prejudiced mind because, some technician must have done it because he has done the casting and he has put in the patient's mouth. We had to really struggle hard for hours to remove them. Again, you see how meticulously the ceramic, metal, and acrylic all are given. See the ceramic, this is acrylic, and this is also acrylic, and this is the metal. All have been given. Okay, and this was fixed in the mouth. Okay, with the help of four teeth. Okay, they would have done the overdenture, done a beautiful work. They should have done the overdenture, but the greed comes in. This is conventionally done. You mix the acrylic in the patient's mouth and you apply teeth. See this? Okay. Again, the casting is involved means this is not a quackery, this is high profile quackery. See how they've given an implant kind of thing. Beautiful they've done. Okay. But then, they must have charged the patient must have paid. Okay. But this happens only when the patient doesn't want to pay much and and he lands up there. We need to really work on them so that these quacks don't exist. So some cases I'll show you what we are doing. This is again a ortho relapse case was there. Okay. So we from there to there, from here to here, you see the we have done the shortening of teeth. Okay. And overjet and overbite both were reduced. So again, uh, very fluorosis case. Okay. Done the prep, both maxillomandibular, and you need to have a proper, distance, entire distance. This is, see, appreciate the margins. Upper ones are your, IPS Emax, and lower ones are porcelain fused to metal. This is because of flash, both are looking whitish, but actually the upper one looks really very beautiful. Okay, last case. This is again an old lady who came to me, and we gave her this kind of result. I'm sorry. Yeah, we gave this kind of result. Again, a good case in which a patient was given a FPD like this. She came to me, we removed the FPD, we did the root canal for all the teeth. This was ectodermal dysplasia case. Gave her a temporary, okay, just for treatment planning, and then the fiber posts were done on the all entire teeth, and we gave her a beautiful FPD. You can see where the central and canine were so close, but we masked that. So you need to have a lot of treatment planning. This is again a patient came to me with a long back and he had a PFM processes, porcelain fused to metal process, which was done by me only. Okay, he wanted much beautiful processes. He was not happy with this. Okay, so we removed this. This is a PFM processor, and we gave him this as zirconia. Okay, so this is zirconia. You can see that there's no metal now. So the temporary I gave. Okay, and this is zirconia. This looks much beautiful, more lively. So this is the PFM processes and the comparison with the zirconia ones. Again, a beautiful case of shade matching. Okay, this is on the cast, the patient mouth. You can appreciate beautifully the shade and match. You really cannot decipher between, you know, what is the original and which one is the artificial. तो टू एयर इज ह्यूमन बट ह्यूमन इज नॉट टू एयर ओनली ओके हमारे से गलती हो सकती है पर हम गलती करते रहे ऐसा अच्छी बात नहीं है ओके तो ट्राई टू बी really very good, try to be very very ethical, try to be very transparent to the patient, okay, and skill and knowledge and experience, they are beautiful combinations. If you have skill and if you have knowledge, definitely you will gain a lot of experience later on, okay, so try to give your best, and if any questions are there then I'm ready to take it. Thank you.
Thank you, sir, for such an insightful and comprehensive presentation. What stand out most to us was how you bridged the gap between the academic theory and the reality of daily general practice. So we have few questions that, as we know
Yeah.
that the zirconia is most popular material now, but unlike PFM, it
Yes.
does not bond mechanically.
Hmm.
So, like many general practitioners face the issue of zirconia crown coming out or debonding after a few months. So, what we can do in those cases?
No, 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 no. PFM also is luted by glass enamel cement, and even zirconia is luted by glass enamel cement. Okay, so both have mechanical bonding. Okay, but whereas if you see that IPS, I mean, there are few labs who give you, if you want to really want the zirconia to be bonded, so there are variolink, there are some many resin cements are there where you will have to use the phosphoric acid, but they don't recommend it because in the posterior teeth they might fracture. Okay, but PFM and zirconia, I mean, if you see the IPS Emax, okay, that is the pressable ceramic ones, they do a chemical bond. Okay, so that chemical bond is because in a pressable ceramic you can use a hydrofluoric acid, 40% hydrofluoric acid is there, and then you can use a monobond. Okay, and then you can bond the tooth with the help of resin cement. Okay, but zirconia can be bonded, but they can be done with the GIC also, like PFM. So
Thank you,
if
sir.
your restrictions are coming off of a zirconia, it means you need to have a control on the taper. You're struggling with the retention and resistance form, not with the cement. No.
Okay. Thank you so much, sir. And I would like to thank our founder and director, Dr. Anmol Ma'am and Dr. Ashish, sir, for giving us the opportunity to host such an good event. And thank you, sir, for all the insightful and detailed view on the FPD.
Thank you. Thank you.
Thank you, sir. Thank you so much.
Okay. Okay.